Namaste. My talk is on clinical examination of knee joint. I'm Sushil Thapa from Bharatpur Hospital. Well, let me begin with the term orthopedic. The term ortho means bones. So when you are examining any joint in our musculoskeletal system, it is not only the bones we are examining, but also the soft tissues around the bones, around the joints. So it's the ligaments, the capsules, the meniscus have to be considered while we are examining the knee joint. The beauty of the knee joint is this is one of the most visible structures, one of the most visible joints. This is easily accessible for examination, and both knees can be placed together for comparison. So it makes our examination easier. We know the bony structure of knee joint is inherently unstable, so it's the capsule and ligaments that stabilizes the knee joint. So these stabilizing structures, of course, have to be examined when we're examining the knee joint. To begin with the examination of any knee joint, we should start from the gait. And gait has to be examined both in acute conditions and also in chronic conditions. But in case of acute conditions, it's painful, maybe because of fracture or maybe because of uh, ligament tear, meniscus tear. So all we can achieve here in case of acute condition is antalgic gait. That may or may not be of so useful, and sometimes we may not advise the patient to walk when in case of acute conditions because the patient may not be able to walk, and we can expect the antalgic gait in case of acute conditions. So in chronic conditions, it carries special significance. Let us take, for example, the patient when the patient walks in swing phase with a flexed knee, the green dot representing the knee joint. If the patient walks with a flexed knee, then it implies extensor lag in that knee joint, maybe because of several pathologies inside the knee joint. Let me take, for example, this particular gait. Right, is that? Uh, Please consider the right knee joint. In the right knee joint, it thrusts towards the lateral aspect while the patient is walking. Right knee thrusting toward the lateral aspect. So this is called varus thrust gait. This this is because of tear of the lateral structures. Like as the famous technique of examination in orthopedics, look, feel, move, measure, and special tests. We also want to follow the this pattern of examination. Let's start from the look here. We look for abrasion, we look for bruises, and these have their special significances here, right? So the abrasion may be present at the site of impact, while the bruises are present at the site of damage. Let us take this example. The opponent, the red jersey one, has hit the blue jersey one on the lateral aspect. So the abrasion may be present on the lateral aspect. But because of this valgus force, the trauma or the damage may be present on the medial structures, that is the medial meniscus or maybe the medial collateral ligament. So the abrasion and bruises have to be very carefully examined for in any knee joint pathology. If the swelling is doughy or fluctuant, it implies hemarthrosis. It may be present in acute conditions, but also in some chronic conditions. Extension lag, valgus or varus deformity may be present in the attitude itself, and the extension lag may be because of several conditions like stiffness or the uh, tibial spine avulsion, the avulsed portion coming into the intercondylar knots, thereby preventing the full extension, or it may be because of bucket handle tear, which has which has caused the extension lag. When we feel for temperature, it may be raised. We also feel for joint line tenderness, and this joint line tenderness may be present in case of meniscus tear. And if it's present in meniscus tear, it's more sensitive as compared to other special tests like McMurray's test or Thessaly's test. So joint line tenderness is very important test for diagnosing meniscus tear, not only for the meniscus tear, but also for other pathologies like MCL tear or lateral collateral ligament tear. The site of tear is equally important. Besides the meniscus pathology, we can diagnose the pathologies on the quadriceps tendon, patella, or the patellar tendon, and other structures around the other bony and soft tissue structures around the knee joint. Effusion is another important finding here. If its cross fluctuation is present, this is grade 4 effusion. We don't need to go for other tests if cross fluctuation is present. If patellar tap is present, again, we don't need to examine for the juxtapatellar hollow test or the Ball's test, right? So the cross fluctuation test implies grade 4 effusion, while the juxtapatellar hollow test implies grade 1 effusion. We want to look for the range of motion. In acute condition, it may be painful, so it may not be so significant. While in chronic conditions, it may be extension lag may be present, or fixed flexion deformity may be present in chronic conditions, maybe of several causes, as I discussed earlier slide. Well, if you're going to examine the extensor lag, it's very important to compare both the legs. Here, the pathology lies in the right leg. Right, this is left, this is normal. Full extension is present. Range of motion is full. While when I examine the right leg, extension lag is present, and this can be compared by lifting both legs at once, so that comparison can be done. It's easier to compare. Extension lag is present. Okay, and in this case, the extension lag was because of bucket handle tear. He's a basketball player, national player basketball. Well, measurement is another important aspect of any examination of the knee joint, right? So when you're measuring, we want to measure the girth of the thigh and also the girth of the calf. So the girth of the thigh is measured approximately 15 centimeters above the superior border of patella. That's because the suprapatellar pulse extends all the way up to 15 centimeter proximal to the superior border of the patella. So if there is effusion, it extends up to 15 centimeters. And if we measure within this 15 centimeter, we may get a false impression of the increased bulk of the thigh muscles. So we want to go above. And there are several special tests. Lastman test being one of the important tests, anti-dry test being another important test, right? We want to compare the anterior draw test with the Lastman test. That's because anterior draw test is done in 90-degree of flexion. And the special anatomy has to be considered before we are proceeding, before we are trying to interpret the Lastman and the anterior draw test. The posterior condyle of the femur is sharply convex on the posterior aspect, right? So this is the medial condyle, sharply convex on the posterior aspect. When you're performing the anterior draw test, that's when you're trying to translate the tibia anteriorly in ACL deficient knee. The this convex portion abuts the medial meniscus posterior horn. So it doesn't it prevents or it restricts the anterior translation of tibia because of this sharp abutment of the condyle. So even in ACL deficient knee, this is less sensitive test. This is called anterior draw test as it's done in 90 degrees of flexion, right? But if it's done in 0 to 20 degrees of flexion, it's the relatively flat portion of the femoral condyle that comes in contact with the posterior horn of the middle meniscus. So, relatively, the anterior tibial translation in ACL deficient knee is not as restricted here as in 90 degree of flexion. That's why this Lastman test, which is done in 20 degrees of flexion, is more sensitive. So the basic factor to consider is the posterior convex point, which aborts with the middle meniscus posterior horn in 90 degrees of flexion. This is called doorstop effect. That's because this is the doorstop. As we are very familiar with our daily um, daily living. This is one of the common structures encountered, and this can be compared. The door can be compared with the femoral condyle. Let us see how this is going to be performed. The Lastman test. The right, this is the left knee, and the examiner's right hand has firmly gripped the thigh, while the left hand has gripped the leg. The left hand's thumb preferably or lying over the joint line, and the patient has to be asked to relax the hamstring muscles, of course, and this can be tested by palpating the hamstring muscles. The tautness can be felt if it's not relaxed. And of course, as in all other examinations, we should examine the normal knee joint at first. And the important point to consider here is the end point, right? It may be hard or it may be soft, the soft end point being more significant. And the translation, it may or may not be present. If we feel like translation is present. Another test is quadriceps active test. This is called sac sign, right? That's because of the PCL tear. When the PCL has been torn, the tibia sags posteriorly. This is called sac sign. And before we proceed to the anterior draw test or posterior draw test, this test has to be done. That's because when we are performing the anterior draw test, we should start from the neutral position, not from the posteriorly sagged position. If we start from the posterior sagged position, this may give the false impression that the anterior draw test is positive and the ACL has been turned. But in fact, this is not the ACL tear, but this is the PCL tear. So we should at first make sure that the sac sign is not present. Well, once the patient is asked to contract the quadriceps, the tibia goes anteriorly. This is called quadriceps active test. It may be difficult to perform in obese patient and in hemarthrosis. This is how quadriceps active test looks like. Okay, the quadriceps once the patient starts. Well, before anterior draw test or the posterior draw test, Saxon has to be looked for, the hamstring has to be relaxed. So, and the examiner sits on the foot of the patient, provided the foot is normal. The knee is placed in 90 degrees of flexion, okay, and the joint line. The thumbs are placed on the joint line so that the translation can very well be appreciated. But again, the important point here is it's the end point that has to be appreciated. So this is how it's going to be performed. The knees in 90 degrees. Examiner sits on the foot of the patient and pulls anteriorly and posteriorly. So when we are performing dry test, It's not other tests are McMurray's test. This is very less sensitive, right? And the idea is the torn meniscus is trapped in between the femoral condyle and tibial condyle, and then it's induced to snap free as you rotate the tibia against the femoral condyles. And this snap can sometimes be heard or it can also be felt. Another important test is Thessaly test. This is performed at 20 degrees of flexion, and the patient is asked to internally rotate or externally rotate the femur against the tibia. So this dynamically reproduces the load transmission, and it's 95% is accurate. This is how the McMurray's test is performed. The knees has to be full range of motion should be present. That's the prerequisite. And if we internally rotate the knee, we're testing for the lateral meniscus, right? And if externally rotate, we're testing for the medial meniscus. And the tibia has to be grinded against the femoral condyles, right? And gradually extended. And the position at which the snap is felt or hard has to be noted. If it's present in full flexion, the pathology is in the posterior horn, mid flexion, body of the meniscus, and if it's present in the full extension, the pathology is in the anterior horn. Now we want to look for the crucial ligaments and the collaterals. Collaterals very important, and it's important to perform the valgus or varus stress test in both full extension and 30 degrees of flexion. If it's present in full extension, the pathology is in the capsule, crucial ligaments, and also in the collaterals. But if it's positive in 30 degree of flexion only, it's the isolated medial collateral ligament or the lateral collateral ligament that has been torn. So it has to be performed in both full extension and 30 degree of flexion. And there are several gradings. This is the degree of opening 5 millimeter, 5 to 10 millimeter, more than 10 millimeters. And the endpoints are hard on grade 1 and grade 2, and this is soft on grade 3. So if it's present in full extension, if the valgus of varus stress test is present in full extension, we may not need to examine this in 30 degree of flexion because we already know the collaterals had been torn, right? But if this is not present in full extension, then we need to repeat it in 30 degree of flexion. Let's see how this is performed here. Okay, now this is in full extension and this is in 30 degrees of flexion, right? The alternative way is to tuck the foot of the patient into the axilla of the examiner and then move it sideways, move the body of the examiner sideways, while at the same time holding firmly the knee of the patient with both the hands of the examiner here. This is especially useful when we are examining the big knees, the patient the when the patient's knees are big enough and the examiner's hands are small enough, then we use this technique, right? And once we make sure that there is no pathology or there is pathology in the MCL or the LCL, then we switch over to another test called pivot shift test. So the prerequisite for pivot shift test is the MCL has to be intact because this is the pivot point for the knee joint while we are performing the pivot shift test. This is the red line represents the iliotibial band, okay, and the green one represents the goddess tubercle. In full extension, the iliotibial band lies along the long axis of the femur, right? And when the tibia or when the leg is internally rotated, right, the tibia subluxes anteriorly. And when you gradually flex it, the iliotibial band comes posterior to the femoral axis. And as it comes posterior to the femoral axis, the anteriorly subluxed tibia gets reduced to its normal anatomical position. And at the same time, we're applying the valgus force, because of which the clunk is amplified, and we can very well appreciate the clunk, right? So glide, clunk, cross. These are three grades, but again, these are very subjective findings, right? And there are several other modifications of pivot shift test, reverse pivot shift test, just to name a few. The two components, important components, are translation and rotation. These are two important components of pivot shift test, and it implies passive instability. Thereby, the patient requires ACL reconstruction. And if it's present post-operative, even after ACL reconstruction, this indicates the requirement of anterior anterolateral ligament reconstruction. Let us see how this is done here in this video. Well, the MCL is intact in this patient, right? And and the patella, of course, has to be examined to complete the examination of the knee joint. The medial and lateral facet tendons can be failed. The patellar grinding test for osteoarthritic changes, or even in chondromalacia patella, the Clark test, patellar glide test, just to name a few tests for patella. And the examination of the adjacent joints, that's the hip joint and the ankle joints, are important. And also the distal neurovascular status has to be examined, like foot drop or compromise of the vascularity of the vessels because of trauma. Thank you very much indeed. This is the this is internally rotated tibia leg, and the valgus is given at the level of the neck of the fibula. The anterior soft anterior endpoint, it's also the posterior endpoint we can consider at the same time. Starts activating the quadriceps, the leg tries to move anteriorly and relaxes the quadriceps. Again, it goes back posterior to the normal position. We should again compare the degree of translation with the normal knee joint. 15 centimeters from the patella. And when you are measuring the calf muscle, it's of course the maximum girth we want to measure. Okay, and ligamentous laxity has always to be need to be considered before we proceed to the special tests. Lateral collateral ligament. So it may be the valgus thrust gate or varus thrust gate, thereby having their own significances, implying the respective structures pathologies.